Okay, so good afternoon, Manish, and good afternoon, everyone. Thanks, Manish, for having me here for this course. And just my two previous speaker, Preeti and Dr. Subhadra, taught us the perimetry and how to evaluate the test and the RNFL. Yes, I do agree with Dr. Subhadra that the perimetry is the gold standard, but structural damage always precedes the functional loss. We see the perimetry changes only when 30 to 40% ganglion cells are lost. Dr. Preeti taught us beautifully that how to examine the test and the RNFL. But remember one thing, if you are perfect, you can do a good, thorough clinical examination of the RNFL and the optic nerve. But definitely you cannot quantify and you cannot monitor the progression just based on the clinical examination. So obviously you need the equipment which is objective in nature, which can quantify and monitor the structural loss so that we can follow up this patient, because glaucoma is a chronic progressive optic neuropathy and it causes a permanent visual damage. So that's why the monitoring of this is very, very essential. And the OCT is the one imaging technology which can fulfill all these things. Interpretation of the OCT is very important. So when you are doing a glaucoma examination, what is important, for all glaucoma patient, you examine the optic disc, you examine the RNFL around the arcuate area, and nowadays the most important is the macular part. Why the macular area is most important? Because almost 40 to 50% of the ganglion cells are in the macular area. So fortunately, the imaging technology is able to assess all these three, the optic nerve, the RNFL, as well as the macular area. What the OCT does? OCT does the scan of this 6 square millimeter area around the disc. And the most important is the 3.43 millimeter diameter around the disc. So where this RNFL is studied nicely and the disc tomography is also studied. What it does, it opens it and it spreads horizontally, and this is classically called the Disney curve, temporal, superior, inferior, nasal, and temporal. This Disney curve is very important because it gives us the information about the RNFL thickness around the optic nerve that is surrounding the 3.4 millimeter diameter from the center of disc. The OCT has a capability of registering the image through the blood vessels configuration, and the center of the disc is also raised, and there is a tracking device where it can be tracked and automatically centered. And you can see that the green area is the very normal. The yellow is the p-value is less than 5%, and the red is where the p-value is less than 1%. So it is highly significant. You can see the enhanced image of this OCT, where you can see that this is a very thick RNFL and this is a very thin RNFL, and you can see that in this area it's dipping, the RNFL thickness is dipping over here. So if you have a complete printout, then what does it say? The first is images of the RNFL thickness, and obviously there is a comparison of the right and the left eye in the same chart. And then is the deviation map. And in the center, you get the tomography where you can get the CD ratio, neuroretinal rim area, and the neuroretinal rim volume, and where the right and the left eye is always compared, and you can see that whatsoever the difference is there, as per the normal deviation, that will be depicted on the color-coded forms. The yellow is less than P is less than 1%, and the red is less than P is less than 1%. And here in this graph, the Tisnet curve is plotted, and where the right and the left eye is compared. So you can see that how much is the symmetry is there between the right and the left eye. You can do a good progression analysis with this. The monitoring of the glaucoma is very important, and so is the progression analysis. And always, with the clinic, we have a less time, so we want a ready-made software. And now this ready-made software is very much available, and it does the progression analysis on the basis of the three things. One is the total RNFL thickness in the 6 millimeter tube area. The second is on the superior hemisphere, and another is on the inferior hemisphere. And this is compared and plotted on the linear regression fashion. And when it is compared, then again, it shows that how much deviation or asymmetry is there between the right and the left eye. So it does give a beautiful progression analysis as well, which you can compare with the GPA of the perimetry. This is the two example. You can see that there is a significant progression over a period of time, and you can see that how much is the asymmetry between the right and the left eye. Now, another important is the GCC, the ganglion cell complex. And this is taking up the momentum these days, and people are more and more concentrating on analyzing the GCC complex. Why so? Because almost 50 to 60% of the ganglion cells lies in the macular area, and the glaucoma is the disease of the ganglion cells. So the GCC is available now in most of the machines, and what you get the thickness map, and you get the significance map over here. And obviously, yes, you get the ENFAS image also, where you can see what is the thickness of the RNFL in the macular area. You can see that this area is little thinner and this area is little thicker. So there is a significant loss of the RNFL, and that you can see that it shows over here in the significance map, which is up there as a red one. So this is again the printout of this, and the GCC you can get along with the RNFL thickness map. This is showing the RNFL thickness at the right eye and the left eye, and alongside you can get the GCC map as well. So both the printout can come together in most of the machines. And you can see that with the GCC also you can assess the progression, and the progression analysis gives the deviation map and significance map. Significance map is very important, and even if you have a less time, just give a brief look, and then you would come to know that the patient is showing a significant progression over a period of time. So there are various imaging machines are available, OCT. The other imaging like the GDX and the HRT, they are out, and manufacturers have stopped manufacturing them. So we have the only one machine available with us, and all the different machines, they have a complete agreement with that. Their RNFL value might be different, but yes, the ultimate outcome is the same. Like in this, you can see that the left eye is showing the significant defect and the right eye is healthy. In another machine also, you can see the same patient, the left eye is a significant defect and the right eye is healthy. In another machine, you can see that the left eye is showing the significant defect and the right eye is pretty healthy. So there is a good agreement between all, but the data is not interchangeable or not comparable. You cannot compare the RNFL thickness of the one machine with the another machine. And there are lots of pitfalls. It's not a good tomogram. You can see that in this, it's just a 0.2 CD ratio. But when you see this, there is almost a near total coupling. So remember one thing, that the OCT is not at all a good tomogram. Once there is a blink, you can see the blink effect. And once you not capture the image, then obviously the disc is totally decentered. Though you can see that it's a very good map, but still you can see that there is lots of defect in the superior nerve fiber layer because the disc is decentered. Here you can see that it's a blinking artifact, and you can see that it's a red disease over here. That is the biggest problem of the OCT. The red disease and the white disease is the green disease is pretty common. This is a blind patient, and still you can see that lots of healthy nerve fiber layer because the glial tissue does not discriminate. So it does not have a normative database in less than 18 years of age. So that's why you cannot use in the pediatric patient. So in summary, the OCT is a good objective test. It can assess the RNFL, ONH, and the GCC. OCT printout is easy to read. It is reproducible. Registration of the image helps in comparing the subsequent report. Two different equipment reports can be compared, and ONH parameter may be different than the observed. Thank you very much for your patience.